This program is brought to you by Emory University.
Good morning. This is Maan Jokadar. It is my distinct privilege to introduce Dr. Clayton Allen Smith, who goes by Tony, to give grand rounds this morning. Tony, Dr. Smith, is a native of Kentucky, and that's where he went to university and then went to Indiana University for med school. He then did his med peds training in Kentucky, and then came to Emory for his pediatric cardiology fellowship training. And then we were delighted when he decided to pursue a career in adult congenital, and more delighted when he decided to work with us for 2 years. And then he joined our faculty this year, and he's been an incredible addition to our team. I call him just about every day with something or another, or a question or a favor, and he always picks up my calls. A few things that you may not know about Tony is that he is an accomplished singer. He performed in theater in high school and in university, though he's not yet performed for us. I'm very much looking forward to his presentation. Dr. Smith, thanks so much for giving your presentation today.
Thank you so much, Mom. That's really nice of you. So I can safely say that I've been very happy to be part of our group here. So good morning, everyone. Thank you so much for allowing me the chance to present to you all today on something that one of the aspects of my job that I am most passionate about. What I'm going to be speaking about today is the past, present, and future of the management of tetralogy of Fallot, and then how the successes that we have had with handling patients with TOF kind of demonstrates the success of a modern multidisciplinary approach to congenital heart disease. So having said that, let's just go ahead and jump right in and get started. And hopefully we're going to have no issues with computer stuff today. So I have no financial disclosures for today. For the objectives of my talk today, I would like to review some of the clinical and diagnostic features of tetralogy of Fallot, just as a general overview. We will then review some of the current data showing the benefits of dedicated adult congenital heart care in both the congenital heart in general congenital heart disease patients, as well as specifically looking at those with tetralogy of Fallot. And then the bulk of today's talk will then focus on evaluating the role of multiple subspecialties and to ensure the best long-term outcomes for this group of patients. And then finally, we will, as part of that, explore some of the novel methods of managing residual disease, specifically pulmonary valve disease in those with tetralogy of Fallot after their initial surgical repair. So to begin, we'll just start with just a general review of tetralogy, given that maybe not all of us see this every day. And any good lecture on congenital heart disease has to have some degree of embryology included. And I'm a pediatrician too, so I also have to know this stuff by heart as a pediatric person. So from an embryologic standpoint, it is thought that tetralogy of Fallot occurs when the muscle forming the interventricular septum just below the pulmonary valve, also the subpulmonary conus, develops improperly and results in anterior malalignment of the septum. And it's that one abnormality that results in the 4 components of tetralogy of Fallot, which is an overriding aorta caused by the anterior lie of the valve kind of being pulled over top of the plane of the interventricular septum, multi-level or an anterior malaligned VSD, multi-level right ventricular outflow tract stenosis, which is caused by the aortic root being malpositioned into the RVOT. And then finally, right ventricular hypertrophy that develops in a response to the RVOT stenosis. This cartoon, one of my favorites, does show the four components of tetralogy of Fallot again. Again, keep in mind that it really is that anterior positioning of the aorta as a result of the deficiency in the subpulmonary conus that results in tetralogy of Fallot. So that really is thought to be the primary driver of development of this disease. The degree of anterior malalignment dictates the physiology and ultimately depends on the degree of pulmonary outflow obstruction. If there's only mild malalignment, the degree of subpulmonary stenosis will mostly be mild. The patient will be described as pink, as the blood flow across the VSD is mostly left to right. These patients are the ones that are at less risk for severe pulmonary outflow obstruction, and generally are the ones that don't necessarily need surgical intervention early on in life. You can wait several months before intervening on them. If you have a more moderate degree of stenosis or more moderate malalignment, the patient may be at risk for intermittent cyanotic spells. There are periods of time in which outflow gradients increase, which frequently happen during episodes in which the pulmonary vascular resistance acutely increases. And because of this, they will normally sit at a mostly left to right shunt, but when the PVR suddenly increases, they can start right to left shunting and become cyanotic. These are the episodes that are typically described in pediatric cardiology as a tetralogy spell or a cyanotic spell, hypercyanotic spell, in which these patients become very irritable and fussy and then subsequently develop cyanosis. And then finally, the degree of malalignment may be so severe that there's complete obstruction of the pulmonary valve and the RVOT, which results in the valve not forming correctly and you get pulmonary atresia. These patients have an obligate right to left shunt and would require early intervention with some sort of management of their pulmonary blood flow, usually with something like a BTT shunt, which we'll talk about a little more later. Of course, I'm a pediatrician, so there has to be a picture of a baby during this talk. So most patients with tetralogy of Fallot early in life present with some mild degree of cyanosis, which usually occurs intermittently with agitation or crying. We can appreciate that in this picture just around the lips. The higher PVR results in an increase in right to left shunting. In many of our older patients with tetralogy, they did not undergo a repair until later in life, usually at several years of life. As a child would age and become more active, the cyanosis would occur more often with exertion. Many of these patients would then squat during their cyanotic spells. Squatting increases your systemic vascular resistance and would typically reverse or decrease the right to left component of shunting during the cyanosis. Most or many of our current adult patients that have tetralogy of Fallot can distinctly remember periods in their early childhood in which they would squat after they would become very short of breath. You can also see in this picture evidence of cyanotic clubbing, also another common feature that we see in people who maybe were repaired later on in life. Here's a classic X-ray finding of early tetralogy of Fallot. This is the the original French description of this, the cour en sabot. My French is not necessarily good. I did take French, but it was Kentucky French. But that's the boot-shaped heart. And looking at a few echo pictures, again, most of these are going to be from infants, but this is a parasternal long axis view in which we show the classic echocardiographic findings associated with TOF. Here we see that override of the aortic valve just above the ventricular septal plane. There's this anterior malaligned VSD. I'm gonna see if I can get the laser pointer out here. And then you'll see the hypertrophy of the RV. Here we're adding color to that same picture, and we can see bidirectional shunting through your VSD. The degree of shunting is generally dependent on the amount of PVR and SVR in that particular moment of time. And it's this physiology that's important to remember in that it is very highly dynamic due to the degree of pulmonary stenosis in each individual patient. Here in this parasternal short axis, we again look at that pulmonary, kind of the VSD sweeping into the pulmonary valve region. So again, we see that malaligned ventricular septal defect, which causes this sprung forward appearance of the septum here, which then is what is creating that obstruction through the RVOT here anteriorly in the picture. Placing color over the RVOT in this patient can show that the RVOT obstruction can be very complex and multi-level. This high peristernal short axis view shows this, where you see flow acceleration both at the valve level and the subvalve level in this particular patient. We can also have supravalve narrowing as well. While most of the examples I've shown you so far have been infants, it is not unheard of for adults to actually present with unrepaired tetralogy of Fallot. This 27-year-old man who initially presented shortly after I began as the ACHD fellow here a few years ago is an immigrant from Mexico and was working as a house painter. Had an episode of syncope while painting during a hot summer Atlanta day, and presented to the Clifton Road emergency room, where he had an ECG done showing a wide right bundle branch block. This echocardiogram was then obtained, and everyone was pretty surprised by these findings. Here we see again that peristernal long axis view showing your degree of aortic override over the interventricular septum, presence of a large anterior malaligned VSD, and again, that sprung forward appearance of the septum here, which results in RVOT obstruction. Again, color shows bidirectional shunting through that defect. And when we switch to a short axis view, we again see that area that's being narrowed caused by that anterior malaligned VSD, which then with color, we see that he had both severe pulmonary stenosis and severe pulmonary insufficiency. And Doppler interrogation of his pulmonary outflow demonstrated severe PS with peak RVOT gradients in the 60s to 70s. This patient's a very nice example of how, even though most CAHD in the modern era is detected early in life, there are still some circumstances when new diagnoses can be made in adults. We should always be cognizant of the possibility of undiagnosed CHD in our patients, particularly in those who may not have had regular medical care throughout childhood. So now that we've kind of covered the just basic background of tetralogy of Fallot and have had a refresher of some of the clinical and diagnostic features, let's talk about the reasoning for why all patients with tetralogy of Fallot should be followed in a dedicated congenital heart center. So this is a slide that is pretty much ubiquitous in every single talk on congenital heart disease and ACHD in particular. This is a fairly landmark study in 2007, which showed overall prevalence of congenital heart disease evaluated over a 10-year course in the 2000s. And what was found is that in both all forms of CHD, as well as severe forms of CHD, that around the year 2000, there was nearly a 50-50 split of adults and children living with CHD in the population. But based off of these projections, however, it was thought that by 2010, that there would be a substantial increase in the adults living with CHD, while overall pediatric numbers would stay relatively similar, ultimately resulting in there being a two-thirds to one-third split. And while this was all based off of some projections, more recent studies have actually shown this to be the case. And in fact, this trend has not only seemed to continue, but it seems like the overall prevalence of CHD in children has continued to remain stable even into the late 20-teens, while the number in adults continues to rise rapidly. And much of this has been attributed to the improved surgical outcomes, medical management, and early recognition of congenital heart disease in the pediatric population. This improved survival in CHD patients is particularly notable in those living with tetralogy of Fallot. This was a recent study done by our group in 2019 that I was part of when I was a pediatric fellow, in which we looked at a large multi-center cohort throughout North America. And what we found was that overall survival of tetralogy with Fallot over the long term was extremely good, with a 30-year survival at about 94%. As we will see later, this effect has been more pronounced in later surgical eras as surgical outcomes continue to improve and recognition of long-term complications have allowed earlier interventions. So why ACHD center care? So I have a few things to say about that. So in this study from 2014, both number of referrals to ACHD centers as well as all-cause deaths within the congenital heart population were analyzed over time. This segment of time was actually of particular interest because in the late 1990s, the first congenital heart guidelines were published. And it was shortly after these guidelines had become readily available that we started to see this increase in referrals to ACHD centers. Along with this, shortly thereafter, there was this noted decrease in overall all-cause deaths within the congenital heart population. While admittedly, this difference in deaths is probably related to a number of different factors, the group was very interested in looking at how care within a referral center versus non-referral center might impact overall survival in these patients. So in that same paper, long-term survival over the course of 8 years between the group followed in a referral center and the patients followed in a non-referral center showed significant improvement in overall survival at that 8-year mark, which was well over 90%. I do think it is important to note that even those followed in a non-referral center still had good 8-year survival, still in that 90% range, but there was a significant difference here. And the suspicion is that as time goes on and there's more pronounced effect of some of these long-term complications that we're going to explore a little bit more here later in the talk, that this effect will become even more pronounced. In recent years, there's been significant interest in developing quality of care indicators within congenital heart disease management. And these have been now developed for multiple different congenital heart defects and have been based off of the published ACHD guidelines, which most recently were updated in 2018. So here we see published quality indicators for patients with tetralogy of Fallot. These are things such as annual surveillance with an ECG, notation of the width of the QRS complex on the 12 lead, MRI assessment of the RV at least every 5 years, echo assessment annually with somebody who has congenital heart expertise, appropriate infectious endocarditis counseling, and heart catheterization being done by those with expertise in cath in those with CHD. This was a paper out of the group in Philadelphia, their adult congenital heart center there, which evaluated the total number of patients meeting these quality indicator outcomes between patients being followed in their ACHD center and patients being followed in non-ACHD center. And what they found is that patients being followed in the ACHD center make quality indicators for definitive assessment of their QRS duration here, as well as meeting their requirements for echo evaluation here, and meeting requirements as far as knowledge regarding infectious endocarditis prophylaxis more consistently than those being followed outside of an ACHD center. I do think it is important to note, though, that in this study, that the vast majority of their non-ACHD patients that were being followed in this study, 39 out of 45, did get referred to an ACHD center, which was an important metric as well. So clearly the groups that they're working with were well versed in understanding that these patients needed to be referred to their referral center. So while these previous studies are not without some issues, they do seem to suggest that patients with congenital heart disease being followed in a dedicated ACHD center experience both improved survival and meet improved quality indicator metrics. And those quality indicator metrics do help detect some of the long-term complications faced by these patients. The question of whether cost of care is improved is also one that is important to ask ourselves as well. This was a study out of a group in Europe, specifically in Belgium. where they analyzed overall cost differences in care between patients being followed in a dedicated ACHD center, here which they called an HSC, a highly specialized cardiac care center, versus those being followed in a joint setting with specialized care and general cardiology care. And then GCC was just general cardiac care by itself. And what they found, and then they divided this group into a mild congenital heart defect and moderate heart defects, which generally Tetralogy of Fallot is considered a moderate to severe type of form of CHD. And then significant differences in cost of care are then indicated by whisker plots that are not crossing the 0% midline here. And what the group found was that compared to those patients being followed in general cardiology care alone, there was a significant reduction in cost of care for those being followed in subspecialty ACHD care. So this effect was seen both with the mild and moderate severity populations. And the effect was mostly pronounced when compared to general cardiology care alone, where they saw a 27% decrease in cost in the mild population and a 25% decrease in cost in the moderate population. And this was thought to be driven a lot by more guideline use, directed use of testing within the subspecialty care center, where, using specific imaging tests or, avoiding use of excessive testing and things like that was more directed within the congenital heart center. So now that we've kind of talked about that patients with Tetralogy of Fallot should be followed within an ACHD center, let's move on to the real kind of meat of today's talk, in which we will review the role of a multi-subspecialty team to ensure the best long-term outcomes in patients living with Tetralogy of Fallot. So the care of the complex patient with CHD requires an interaction between multiple subspecialties. Generally, the ACHD cardiologists are considered the quarterbacks, kind of monitoring long-term conditions, getting annual testing, kind of monitoring those quality metrics that we talked about earlier. And then we have multiple subspecialties that help us with issues that may arise. So we have our congenital CT surgeons, as well as surgeons outside of congenital that help us with various surgical needs that come up. We have advanced imaging that helps us get extra pictures that might help direct us towards whether or not pulmonary valve replacement is indicated or whether other interventions are needed in these patients. We have our congenital electrophysiology team that helps us manage the high frequency of arrhythmias that occur in this patient population. And then finally, we have our structural interventional team that help come up with solutions for valve replacements and other interventions when surgery may not necessarily be indicated or possible. So let's review each of these in turn, starting with our congenital CT surgery. So one of my favorite parts of being a congenital cardiologist is the history of the field as a whole. And the field is really full of interesting personalities and stories. And for anyone that hasn't really reviewed this in the past, I highly recommend that you review some of the literature or one of the many books that are out there on how the field of congenital cardiology came to be. Not only was it important for what I do and the rest of my team does, but it actually played a definitive role in shaping all of modern cardiology today. And I find that TOF in particular is one of the most fascinating stories in the pediatric cardiothoracic realm. So it starts with these two people. The woman on the right here is Dr. Helen Tausig, who was one of the early pediatric cardiologists. She attended medical school at a time when women were not necessarily given the number of opportunities that they deserved. And when she graduated medical school, she found that most of the quote unquote in-demand specialties were taken. She had wanted to go into internal medicine, but one of the other women in her class was actually accepted, and she was not really permitted to go in that route. So she then went into pediatrics instead, and there was pushed towards cardiology. and which was at the time thought to be really a dead-end specialty. It was a lot of patients that were called the quote unquote blue babies, which were primarily children born with tetralogy of Fallot, who generally died young because of their cyanotic heart disease. Well, in 1945, Dr. Taussig approached Dr. Blaylock, Alfred Blaylock here on the left, to create an alternative source of pulmonary blood flow. She had noticed that in her patients, that patients with a patent ductus arteriosus generally did better over time, and she basically asked Blaylock to help her build a ductus for these patients. Fortunately, these two had the pleasure of having this gentleman, Vivian Thomas, actually work with them as well. Mr. Thomas was actually a custodian who had turned into a research assistant / surgical assistant of Dr. Blaylock's. And he was really instrumental in developing the first subclavian to pulmonary artery anastomosis, which was later called the Blaylock-Taussig shunt, and then recently has been renamed the Blaylock-Taussig-Thomas shunt, or the BTT. So the development of the Blaylock-Taussig-Thomas shunt led to a rapid sequence of new interventions to try to improve the lives of young people living with tetralogy of Fallot. In 1946, the Potts shunt, which was a descending aorta to LPA anastomosis, was developed. And then in 1948, something called the Brock procedure became described in the literature. And what the Brock procedure is a closed infundibular resection, which was also considered a palliative procedure. At the time, full repair was not yet being performed. In this patient, the VSD is actually left alone and not repaired, and a small ventriculotomy was created in the RV wall. And this biotome-like device was basically inserted into the RVOT, and then little snippets of tissue were taken out to open up the RVOT. The procedure itself was fraught with complications, including injury to the conduction system and pulmonary valve. And with the advent of open cardiac repair, has now become obsolete. In 1954, this gentleman, Dr. Walt Lillehei, who is considered one of the founders of cardiac surgery and congenital surgery specifically, described the first intracardiac repair of tetralogy of Fallot, in which he did a closure of the VSD and resection of obstructing muscle bundles within the right ventricular outflow tract. He then presented an 11-patient case series in which he used cross-circulation bypass, which is demonstrated here in this picture, in which the patient's own parent was used as the bypass machine. This was one of the only historical surgeries that had a possible 200% mortality, because you could potentially lose your patient as well as the bypass circuit, the parent. 6 of these patients that he operated on were less than 2 years old at the time. And then he would also go on to describe the first transannular patch type repair in 1956. In 1962, the Waterston shunt was described, in which an ascending aorta to RPA stenosis is created. And then into the late 50s, early 60s became the advent of whether operating on patients early in life doing a repair or waiting until later was the ideal strategy. Generally, at this time, early repair fell out of favor due to rising mortality rates related to surgical approach and the use of not very good bypass circuits. So most centers turn to stage approaches, in which a BTT shunt, or one of the other types of shunts, was used to correct cyanosis and allow growth for months to years prior to surgical repair. It was in 1974 that Dr. Castaneda and colleagues in Boston described their approach to early full repair of tetralogy of Fallot. And with improvement in bypass management and technology, outcomes improved significantly during this time. And then it was in the early 1980s, the initial description of the modern day modified BTT shunt was performed. This includes the use of artificial graft material to create the shunt, rather than sacrifice of a subclavian artery to actually form the anastomosis there. So the original most popular approach to tetralogy repair was use of a sizable ventriculotomy. Primarily, there have been two surgical approaches described in the past literature, the ventricular approach and the atrial approach. So in this panel, we see the initial step in the ventricular approach, in which a large ventriculotomy kind of across the pulmonary valve into the right ventricle was made. And we then are able to use that hole to visualize the ventricular septal defect, and that is then closed by the surgeon. And then they will then use a patch over top of that ventriculotomy to open up the RVOT and relieve any sort of obstruction there. The patch is generally left a little loose at its ends to help augment both the MPA and LPA side, as well as the RVOT infundibulum area. And then the surgeon has to be quite careful in placing their sutures, because they are going to be very close to both coronary locations, specifically the LAD and the long anterior ventricular branch. And getting within just a couple of millimeters of the coronary can place tension on the coronaries. In situations where the pulmonary valve annulus was thought to be big enough, the surgeon could also do this approach, in which a ventriculotomy below the pulmonary valve is made, as well as another incision above the valve is made, in which they can then patch open any areas of narrowing within the MPA or the RVOT. This is generally considered to be what's called the valve-sparing approach to tetralogy of Fallot repair, and was reserved for patients with an adequately sized pulmonary valve, which we'll discuss a little more. So transventricular repair was thought to have pros of being a little more technically easier, good surgical survival, and can generally be performed in patients at a younger age. Unfortunately, they do seem to have the need for more intervention later in life due to the need for pulmonary valve replacement. They may have more arrhythmia, and they may be associated with decreased long-term survival, which we'll discuss here in a few minutes. And ultimately, a lot of these patients undergoing a large ventriculotomy end up with something like this, in which the RV has, the pulmonary outflow has chronic free pulmonary insufficiency, resulting in RV dilatation and then subsequent right ventricular dysfunction. The transatrial approach came later and was first fully described in 1981, and has generally become the surgery of choice for repair of tetralogy of Fallot at this point at most centers. So in this case, the MPA and branch pulmonary arteries are first dissected free and mobilized. There then has an incision made in the main pulmonary artery, which allows visualization of the branch pulmonary arteries, as well as the pulmonary valve from above. And then along with this, an atrialotomy incision is also made. This allows for visualization of the ventricular septal defect through the tricuspid valve, and it is through that approach that the VSD is then repaired. This slide shows suggested pulmonary valve annulus management strategy depending on the size of the annulus. So smaller valves, with a smaller Z-score, are generally thought to be those that would require an augmentation, while larger valves are thought to be able to be left alone. So it's really that -2 cutoff for the Z-score of the valve that we use when we're making this surgical decision. There have been some interest in using this for very small valves, in which a very small kind of limited transannular incision is made, and that this has been kind of a growing area of interest in order to preserve the valve better. Here, the VSD is subsequently closed, as we saw, through visualization through the tricuspid valve, and then frequently a small PFO or atrial septal defect is left after the patient comes off bypass, in order to allow some pop-off at the atrial level, in which we trade a little bit of mild cyanosis with improved cardiac output, as the RV will usually be still quite restrictive in the immediate post-op period. The surgeon will then finally do an RVOT reconstruction, usually with patch over the MPA to relieve any sort of MPA or branch pulmonary obstruction. So the transatrial repair approach is thought to be a little bit more technically challenging, but does not require an incision on the RV, which is thought to probably help the RV over time and have less RV scar. Again, overall surgical survival and surgical results have been good. And there is also thought to be this protective effect on the pulmonary valve and the RV in general, in which the valve is left to be more functional. Cons of this are that they do feel like it is a little more technically challenging, maybe a little bit more difficult to perform in very young or very small patients, and may result in some residual RVOT obstruction, which may require a repeat intervention.
Right over here.
I think somebody may not be muted. There have been some questions about staged approaches. This
Wow, I'm sorry to hear.
Adequate pulmonary blood flow, touched on earlier. And then this allows the patient to get larger before you do a more complex surgery. But there is unfortunately a trade-off with this, in which there's a significant risk of mortality with shunt physiology. So why is this staging so important? Because there is a significant increase in mortality in these patients. So this study from 1998 basically looked at overall mortality in those that had gone under primary versus staged approaches to repair over 3 different surgical eras. And really throughout all 3 eras, although less pronounced in this middle era, there did seem to be a significant worsening of overall mortality in those patients that underwent staged approach. And what they also showed in this same study is that this is looking at need for repeat RVOT intervention. Really, there was no significant difference between the staged and primary approach. So overall, those undergoing primary initial repair actually did quite well. So based off of these results, many centers have come up with algorithms such as this, looking at the overall status of the child and whether or not cyanosis is present, the child's size, and then the size of the native pulmonary valve to make decisions as far as how to approach their surgical repair. So just as a refresher to your memory, this was a study done from our group a few years ago, looking at long-term survival in a large TOF cohort in a multi-center registry. And as part of our study, we also showed that overall survival is actually significantly impacted by some of these early surgical decisions. So 2 of the most important modifiable variables that we found was that those who underwent primary repair, this gray line here, seemed to have improved long-term survival over those that had staged repair. And then those that actually underwent a valve sparing type repair in which the pulmonary valve was left intact also seemed to have better long-term survival than those in which the valve was sacrificed or made incompetent. A similar study from a group in Europe published in 2019 looked at something similar, in which they looked at different surgical eras. And again, somewhat not surprisingly, long-term survival has improved in later surgical eras. This 2017 study out of Australia showed again that overall survival in tetralogy of Fallot, usually at that 35 to 40 year range, was still quite good. However, this group found that there is a much more significant percentage of those experiencing long-term morbidity after their repair for TOF. And what they found was that greater than half of all patients experience morbidity by the time that they are 50 years old, including serious events such as death, need for heart failure, hospitalization, or documented ventricular arrhythmia, or other all adverse events, including atrial arrhythmia, endocarditis, or need for implanted device. Why do we think this long-term morbidity and mortality happens so frequently in this population? Well, this landmark study from 1995 evaluated a group of 178 patients with tetralogy of Fallot, looking at a number of different features, but found that all patients that had experienced sudden death or sustained ventricular tachycardia caught on a Holter or resulting in syncope had a QRS duration above the 180 millisecond mark. This all correlated with echo data showing that this 180 millisecond mark corresponded with an increase in RV enlargement as well as a worsening of pulmonary insufficiency. So this is really what kind of pushed us into thinking that the status of the pulmonary valve probably plays a major role in long-term morbidity and mortality in these patients. One of the most challenging aspects of management within this population, though, is determining when a new pulmonary valve might be indicated. And I think I'm a little biased with this, but I think this is one of those questions where use of advanced imaging can be very helpful in determining that timing. So in 2013, the group out of Boston evaluated a number of criteria for PVR, and the recommendation has been that generally any patient with asymptomatic tetralogy of Fallot with moderate to severe PR and with two of any of these criteria should undergo pulmonary valve replacement, and those with symptoms and one or more of these criteria should also have a valve replacement. And these criteria from 2013 have formed the recommendations based in the 2018 ACHD guidelines. And those same guidelines have now placed a significant emphasis on the need for ancillary testing, particularly of cross-sectional imaging in patients with CHD. TOF especially has had significant emphasis of CMR and CTA being recommended every 1 to 3 years, depending on the patient's clinical status. And much of this comes from the fact that assessment of the RV by echocardiography is fraught with difficulties. So as most of us know, the assessment of the RV has been an ongoing challenge for many, many reasons. The RV has an unusual shape. There's complex trabeculations that are hard to evaluate. There's difficulty in evaluating the relationship of the tricuspid valve to pulmonary valve. And many of our patients have very challenging windows given the anterior lie of the RV. There has been significant interest in the use of 3D echo to evaluate the RV as a tool in assessing RV volumes. Our group has been exploring this and have shown that assessment of the RV is reproducible and consistent with the use of 3D echo. We've been able to compare RV volumes obtained by 3D echo with the gold standard of volumes obtained by cardiac MRI. And in limited numbers, we've found that in the hands of an experienced sonographer with good, reasonable echocardiographic windows, that 3D RV volume measurements are similar to those obtained by MRI. So in this patient, we got an RV end diastolic volume of 241 with an indexed volume of 102. When this patient was compared to the MRI that they also underwent, that was within about 5 cc's on the absolute value and within about 8 or 9 of the indexed value. So actually quite good there. Further work in looking at this is necessary to show reproducibility of these results, and obviously there is some patient selection that goes on as far as good windows and whatnot to get these kinds of images. The question of when a pulmonary valve replacement should be performed in TOF patients still remains somewhat unclear. This 2005 study published in The Lancet showed that patients that had an indexed RV volume of 170, that placement of a pulmonary valve no longer normalized the right ventricular size. So current ACHD guidelines have now settled on a value of 160 ml per meter squared as the end diastolic volume indicative of need for pulmonary valve replacement. use of cardiac MRI has allowed us to look at RV volumes before and after pulmonary valve replacement. And in this study, we found that RV volumes were found to significantly reduce after PVR compared to that of the LV, which were basically unchanged. Importantly, in this population, the RVEF did not change. It stayed 42% before and after PVR, which does suggest that there does become a time that once the RV function starts to drop, you can no longer restore it despite placement of a pulmonary valve. A critical question with all of this, though, is whether sudden death risk improves with pulmonary valve replacement. And in one study, the QRS duration was found to stabilize, although it did not worsen, it also did not improve. Incidence of monomorphic VT did improve. However, overall risk of death did not seem to change. So it makes us think, is there really a significant benefit doing PVR as far as a risk of sudden death in these patients? This recent study out of Boston, in which they looked at a primary endpoint of death, sustained VT or aborted sudden death or advanced heart failure symptoms, in which patients were evaluated pre and post PVR. And what they found was, despite a significant improvement in the right ventricular end diastolic volume after PVR, there was no significant difference in the RV EDV of those that experienced the primary outcome and those who did not. And what they found was that really the variables that suggested an increase in these primary outcomes, again, death, sustained VT, heart failure, or aborted sudden death, they found that the main differences here were either a abnormal post-PVR RVEF, presence of atrial arrhythmia post-PVR, or a difference in age. And what they saw was that the patients that were having the primary outcome generally were older, about 35 years, compared to those that were 23. This also held up in a multivariable model, again showing that age, the post-RVEF, and atrial arrhythmia remains significant for the primary outcome. Overall, this study has called into question some of the RV volume-focused indications for pulmonary valve replacement. Switching gears a little bit, there's been some interest in other forms of non-invasive imaging in the assessment of tetralogy of Fallot. So this image, for those who might not be experienced with this, is actually 4D flow MRI. So in this, we obtain flow data through all three planes over time in a patient, and then we can reconstruct it into these flow vectors. So this image, which was done over at Children's, shows a patient with tetralogy of Fallot that has significant pulmonary valve regurgitation. This patient was known to have a very large MPA aneurysm, which we see here, kind of this white shadow in the background. And what we see when looking at flow is, as the flow comes through the pulmonary valve, it creates this turbulent flow that kind of gets stuck in the MPA, which shows you why this area dilated so much. We also see here significant degree of pulmonary valve regurgitation. 4D flow MRI may offer some multiple advantages over other MRI techniques in the assessment of both tetralogy of Fallot and other forms of CHD. This study out of Italy, where a lot of 4D flow research has been performed, assessment of pulmonary flow values by both 2D and 4D were obtained. And what the investigators found is that 4D flow was as accurate in evaluating pulmonary valve flow as traditional 2D flow, and in some instances may be more accurate. This was particularly pronounced in those that may have very complex flow patterns through the pulmonary valve and into the branch PAs. Ultimately, though, more work is needed to evaluate the utility of 4D flow and assessment of both tetralogy of Fallot and other forms of CHD, other than creating those really cool pictures that I showed you. As we have seen, rhythm disturbances play a major role in the long-term morbidity and mortality of the population, and incorporation of a dedicated EP specialist is essential to management of these patients. In this study from 2013, overall prevalence of arrhythmia in the tetralogy population by age was evaluated. Significant portion of the repaired TOF patients have both ventricular and atrial arrhythmias, and this becomes very pronounced in the 4th and 5th decades of life, with nearly 50% having some form of arrhythmia by the time that they are in their 50s. This study from 2008 has looked at factors associated with an appropriate ICD shock in tetralogy. And what this group found was that high LV end diastolic pressures, not presence of non-sustained ventricular tachycardia, a history of ventriculotomy, and a increased QRS duration all seem to be associated with increased risk for ICD shock. Obviously, some of these more strong than others. Inducible sustained VT also was a factor that was incorporated in this as well. Based off of these findings, a risk stratification score was suggested, and this score can be used to help estimate the likelihood of an ICD shock 10 years post-transplant in the tetralogy population. So we should be very aware of these issues in our patients and be concerned about anybody with an elevated score having a high likelihood for having VT that would need to be shocked. What about the utility of cardiac resynchronization in these patients? This is a very tough question because in many of these patients, typical features supporting CRTD are not always found. But in almost all of these patients, there's a substantial lengthening of the QRS by a right bundle branch block. This was a small study by our group in 2013, in which patients were divided into two groups. Group A was a group that was getting a new CRTD device from no prior pacemaker. And then Group B was having an upgrade from RV pacing. Both groups had low EF and symptoms of heart failure. And what was found is that there was a significant improvement in LVEF and a decrease in left ventricular volumes in the midterm, which was 8 to 10 months after implant, with continued improvement, although no longer clinically significant or statistically significant in the longer term from their baseline. So there does seem to be improvement with CRTD, although the applications of this are still somewhat unclear in this population when they have heart failure. Finally, let's end our discussion reviewing non-surgical interventions for tetralogy, particularly involving non-surgical valve replacement strategies. And this is where we incorporate our structural interventional team. So over the past decade or so, there's been growing interest in the use of transcatheter valve replacement in the TOF population. It's now been about 10 years since the Melody valve was first deployed. And we use a team approach to do this with looking at patients who are good candidates for TPVR, using both cross-sectional imaging and the structural team. So this was a 16-year-old who had a history of pulmonary atresia, who had a conduit placed with conduit stenosis, and cardiac MRI was used to assess the conduit for sizing. And we were able to make this nice 3D image to show kind of where the valve would need to be landed. And then we use 3D imaging to actually give the measurements that are needed to size the valve. Along with this, we then can look at other factors that may preclude our ability to place a valve. So this is another patient with an RV to PA conduit here. And 3D assessment showed that this patient had a coronary artery lying just below the location of where a new valve would have to be placed. And on 3D assessment, we see that he has a single coronary artery system with an LAD that lies just below where his pulmonary valve is located. And because of this, there was concern that the LAD would be compressed by placement of a new valve, and the patient was instead taken to the operating room for surgical replacement instead. So the question of whether surgical PVR is needed is a good one. Generally, surgical PVR has been preferred historically. But in many of our patients, they're considered high risk for multiple reasons, either comorbidities or late presentation resulting in heart failure. There have become interest in alternative approaches, and this is where the Altera and Harmony RVOT reducers come from, in which these stented landing zones are placed within the RVOT, allowing placement of a valve within them. What does this look like? So this was a recent Altera candidate that we did here, in which the Altera stent is placed within the RVOT. After this, we see deployment of an Edwards Sapien 3 valve within that pre-stented area. And then that valve was functioning very well afterwards. This patient, in some patients, the Altera or Harmony may not be available due to the degree of RVOT dilatation. It just gets too big for even that stent to lie. So in this patient with tetralogy of flow, we noted that he had severe pulmonary insufficiency and progressive RV enlargement with symptoms of heart failure. We felt that he was a poor surgical candidate due to multiple comorbidities. He had severe TR, he was morbidly obese, and he had restrictive lung disease, so surgery was felt not to be possible. He then was evaluated for possibility of an Altera. Unfortunately, his RVOT was very dilated, so it was felt like that would not be able to have a good landing zone. So this approach was taken. So what we see here is bilateral endografts being placed within the RVOT, one going out to the LPA, one going out to the RPA. And then within each of those endografts, we now see deployment of a Edwards valve into each one. This left the patient with this situation in which he has now two pulmonary valves, one in the RPA, one in the LPA. Both valves were functioning very well off of echocardiography. And then this again shows those valves nicely. And then this is a 3D reconstruction by CT of that orientation of his stents. This was one last example in which a patient who was in her late 70s, who had had long-standing pulmonary valve regurgitation, had gone unrecognized and untreated, who was actually quite active and fit, but had noticed worsening exertional symptoms over time and progressive RV dilatation. So it was recommended that she undergo PVR. She was again deemed a higher risk surgical candidate, and there was concerns about, given her age, recovery from surgery. So transcatheter options were considered. She underwent this approach in which a large endograft was placed within her RVOT, which we're slowly seeing deployed here. And they're actually ballooning it into place now. And then, so here we are again, kind of ballooning and deploying this endograft. And then she had stents placed through a fenestration that was created by the surgical team at the time of initial prep. And through that fenestration, a stent was being placed into the right pulmonary artery. Ultimately, she had a second stent placed to maintain patency to the RPA. A valve and a Edwards valve was then implanted within that endograft. Here's what she ended up with. So this is a 3D reconstruction by CT showing that endograft here going out to the LPA. And then as we rotate to the back, we can see the two stents heading off to the RPA. And then there's a valve right here that is now functioning. And she was left with a good surgical result with an excellent functioning pulmonary valve with no significant residual pulmonary regurg. So in conclusion, tetralogy of Fallot is one of the commonest forms of CHD and overall has excellent long-term survival of above 90%. There are multiple benefits to having tetralogy of Fallot and other CHD patients followed in a dedicated ACHD center. And then ideal long-term outcomes in TOF require close cooperation between multiple subspecialties. With new imaging and interventional techniques, we are revolutionizing the management of tetralogy of Fallot in the modern era. I want to thank all of my team. I wasn't able to include pictures of everybody, but it really does take a village for all of us to take care of these patients. And with that, I'm happy to take any questions or comments that you may have.
Dr. Smith, that was fantastic. Congratulations on a fantastic job.
Thank you, Mark. I appreciate that.
I have a question. Who do you think, which patients do you think need to be referred for subspecialty care? You know, particularly patients who live far away. It's sometimes a more difficult decision. We collaborate a lot with our local cardiologists, but want to sort of get your sense on that.
I think what we've shown is that, you know, especially for moderate to severe and even some more mild forms of CHD, that really all of them should be followed to some degree in a subspecialty center. Interestingly, that study out of Belgium did look at that question, where there was some kind of mix and match between general cardiology and subspecialty care, and they did show that, you know, at least from a cost standpoint, that when you put patients in subspecialty plus general cardiology care, that costs were better with the combination approach when compared to just general cardiology by itself. I think given that so many of our patients come from so far away, I do think that in select people that team approach is very important and one that we use a lot. And I think that fortunately the rise of telehealth has made that even more possible. So I think the short answer is I think everybody needs to be seen, at least some, but I think there is a lot of chances for collaboration between general cardiology and subspecialty groups.
Tony, there's a question from Dr. Mehta. Amazing talk, thanks so much. I'm curious, how often do we use CPET, cardiopulmonary exercise testing, to make decisions on pulmonary valve replacement?
I think that's a great question. I think, you know, CPET has become very useful in those patients that you may have imaging findings that are concerning, but they may not necessarily meet complete criteria yet. And the patient themselves is saying that they feel fine, which we see a lot in our young patients, especially our 20-somethings that may not want to have surgery or anything. I know of one particular case that I saw personally in which, you know, his RV was quite dilated, his pulmonary valve was quite in bad shape, and he said, "I feel perfectly fine." We put him on a treadmill and he did absolutely terribly. So with that information, we were able to kind of convince him that it was time to go ahead and replace his valve. And after his valve, he actually feels remarkably better. So I do think it has a role. I don't think it's necessary in maybe all patients, but I do think it can be a very helpful tool for us.
Dr. Searles asked the question, is there an opportunity for molecular therapies, cellular therapies at any level in managing tetralogy Fallot?
That is an excellent question. I don't know if I have a complete answer to. You know, I think there is certainly a lot of interest in this from a standpoint of other forms of CHD. I think the challenge here is that sometimes it's hard for us to recognize exactly where the you know, initial problem came from. You know, we don't know if there's probably a genetic role. We don't really know why the underlying embryologic abnormality happens, but I think figuring that out may be, you know, it might be the way to put us out of the job if we could cure a lot of this before it even becomes a problem. So I certainly think that there's some interest in finding these targets on a molecular level, but I think that is a long ways off at this point.
Given Dr. Searles' expertise, I'd like to ask that same question of Dr. Searles.
Yes.
Charlie, you there?
Yeah, sorry, man. I don't know, actually. I know that Mike Davis is doing a lot of work with congenital heart disease in general, but I don't know if he uses cardiac progenitor cells, and he's actually got a trial going, I think, but I don't believe it's with Tetralogy of Fallot. It's with some, I think it's single ventricle.
Yeah, I think that's the hypoplast trial. Yeah.
Yeah, but I mean, certainly, I think his kind of work is creating some optimism, I think, for use of at least progenitor cells or some form of stem cell for some of these management possibilities.
I think it's a great question and a really interesting one. I think if we could, ultimately we have to have the target first. We know what goes wrong in a lot of these diseases. We may not just completely understand why. But maybe once that's better understood, it will give us some of those targets.
Yeah, and I think also in the era now of gene editing is going to be there's be opportunities for this to, as you identify targets.
Absolutely.
Well, we're a few minutes over time. Dr. Smith, thank you again for a fantastic talk and strong work.
Thanks, Dr. Jogar. I appreciate it. Thank you all for your attention, and sorry to keep you a few minutes late.
The preceding program is copyrighted by Emory University.